Let's get moving on so we can get out of here. This is emergencies in the geriatric population. So you have to be nice to me. As if you wouldn't anyway, right? Oh, let me get this thing turned on. Okay, there we go. Well, yes, I am among the fastest growing population in the country. Due to a lot of reasons, not the least of which have been no major anythings happening, but also because of the baby boomer population, obviously, which happened right after me. Theoretically, healthcare and living standards have improved significantly since World War II. However, that's probably reached the peak. But by 2030, we are going to have 70 million people in the United States 65 or older. Yeah, some of you will not be there yet, but okay. As you get older, a bunch of things change, and things do sort of run down, despite what the ads for various medications hold out. Your body becomes less efficient with age. Among things, you have decreased circulation, both because of atherosclerotic disease of the vessels themselves, but also because the heart becomes less efficient and has less cardiac output. Gastric absorption decreases, so you fail to take in certain amounts of nutrients and medications. Absorption and distribution throughout the body is slowed, and there are decreased bodily fluids. We'll get back to that. As we age, we get comorbid diseases, diabetes, atherosclerotic cardiovascular disease, renal failure. Elderly patients, more than 70, seem to accept medical problems as part of aging, so they sometimes ignore them or ignore them for economic reasons. There's communication challenges with the elderly. This is important, and it's going to be more important to you as you get older, but also as we sort of devolve in the paramedic business, there may be a little bit more, there's a movement afoot to have paramedics take a little bit more role in what's called community medicine. In other words, that in some places, Colorado, Dallas, Texas, paramedics are making essentially house calls. I'm not saying that that's going to happen up here, but one of the things they're finding out is that it's hard to deal with regular medical problems of elderly people because communication is a real issue. And it's not like you just go in and say, yep, there's blood on the floor, I can take care of this. You go in and start talking to somebody who has difficulty seeing you and writing and reading because of cataracts and glaucoma, and difficulty hearing you because of chronic tinnitus, ringing, buzzing in their ears, and or even Meniere's disease, which is intermittent tinnitus in one ear associated with extreme vertigo and nausea, vomiting. Speech is difficult, gets more difficult with age, particularly if patients have had strokes or had other problems. Mental status changes, organic brain syndrome and senility may come on fairly quickly. There's a number of, ultra mental status falls into everything from medical traumatic head injury, heart rhythm disturbances can cause mental status changes, infection, medications, particularly too much medications because of a bunch of reasons. Hypothermia, hyperthermia causes mental status changes. The point is, don't assume that a confused or disoriented elderly person is simply senile just because their mental status is altered at that moment. Now, I mentioned already physiologic changes with age. You have decreased circulation, both cardiac output and delivery because vessels are stiff. Gastric absorption decreases and distribution is slowed, distribution throughout the system. Decreased body fluids makes a great deal of difference. When you have decreased fluids, whether it's dehydration or just simply relative decrease in body fluids, drug concentrations are increased. Also, the elderly have a tendency to have decrease in protein in the serum, albumin particularly. Albumin decreases. Less serum protein equals more free drug, so the same dose that you take when you're 25, if you take it when you're 75, it may have twice the effect because of the combination of drug concentration increase, decreased body fluids, and less protein binding. Now, not all drugs are protein bound. And we're going to talk about some drugs and problems down the way. Certain silly things that you wouldn't even think about, like grapefruit juice, makes a great deal of difference in the absorption and the metabolism of drugs, particularly in the elderly. Now, toxicology, pharmacologic toxicology is very big. It's estimated that there are probably 20 to 25% of hospitalizations in the elderly are due to drug interrelated problems. Usually increased drug interactions, one drug with another, or decreased compliance with medications, and increased adverse effects. Polypharmacy is rampant in this country, as we know. If you have one doctor and you're 70 years of age, you probably are getting 4 to 6 medications from that physician. If you have 2 doctors, you're probably getting 8 to 12 altogether. And this is exponential. It just keeps adding up. And the more doctors you have, so if you have an internist, a cardiologist, a nephrologist, a diabetologist, and an ophthalmologist, you're probably getting a batch of drugs, and nobody knows what you're getting for sure, because nobody has a family physician anymore in the sense of someone who takes, total care. Factors that then decrease the compliance in the elderly are compliance with medication, is medication errors. They're confused over the dose. Anybody pick the prescription up recently? Most of the time on those boxes you cannot read the dose and the amount and how you're supposed to take it. If you're my age, you cannot see those things. It's getting too small. They self-medicate. Over-the-counter drugs. Nobody counts over-the-counter drugs as medicine. Nobody counts aspirin. If you ask them, are you taking medicine? No. Okay, what about aspirin? Oh, yeah, I take aspirin every day. What about Tylenol? I take Tylenol every day. What if, on and on and on. The only thing the elderly don't have is they don't take birth control pills anymore, so that they don't call those medications either. Herbals. Herbals are very big. We have a couple slides on herbal medications. They're very big in this country. And there's a lot of interactions with medications that people are supposed to be taking, particularly anticoagulants. They get medication from their neighbor. They recommend something that says, hey, if this works, you're having a little, you're feeling a little dizzy, take one of my nitros. Well, it makes sense to me. And they do a lot of doctor shopping because, competent, honest physicians don't generally give you a medication just because you show up in the office. They theoretically give it to you because you need it, but you can generally shop around to find a physician to give you what you want. There's a whole problem with compliance with medications because the cost. They may skip doses. They figure if they're supposed to take 2 a day or they can just skip one dose per day and get away with it, skate by. They may forget to take the dose. They can't read the label, as I said, or they can't open the bottle. If you want to see somebody with basically rheumatoid or just osteoarthritis, a little old lady try to open a pill bottle, a child-proof bottle. Now you can get any child to open that bottle, and probably the impaired children open the bottles much better because they put it in and pop the top off of their teeth. So kids can always open the bottle, but little old people cannot. The risk factors for poor compliance with medication: you live alone. Very big with elderly people. No regular or family doctor. Physicians will not take new Medicare right now. They will probably in the near future. Forgetful, depressed, alcohol abuse, no insurance and fixed income. Costs money to buy pills. If you have 4 to 6 medications it's very easy to come up with. Well, the fact it averages out to be about $80 a month per medication. Now, some of them are really cheap, and some of them are really expensive, but it averages out. If you have 10 prescriptions, you're spending $800 a month. And your insurance doesn't generally pick that up for quite a while. There's a big gap in the Medicare gap thing. Now, the elderly take the same kinds of medications that young people and middle-aged people do, but they have different effects on them. So, benzodiazepines, Valium, when I picked on Rick Futrell last. When Rick started paramedicine, Valium was the #1 prescribed drug in the world, not only in the United States. I'm not sure if Rick was on it or not. I don't think so. But more than likely not. But benzodiazepines have been very popular for a long time because they mellow you out. Xanax now is at the top of the list of the bad guy list for the FDA because it's highly sought after because it works out really well to mellow people out who are on methamphetamine, among other things, and it's highly addictive. But with elderly people who get any of those drugs, Klonopin, they may be taking it for seizure disorder, may be taking it for restless leg syndrome, may be taking it for a bunch of things. Librium, Restoril, very, very commonly prescribed. But in the elderly, as you have more drug effect because of the protein and the binding, etc., you get ataxia. You can't walk straight. That's a normal effect of an overdose of any of these things. Just like any of the anti-seizure medications, if you take too much, ataxia is one of the symptoms. Nystagmus and ataxia. But elderly at normal doses will get ataxia, dizziness, confusion. The drugs interact with digitalis. If you're on it, they will keep levodopa low. So if they're taking a medication like Klonopin for restless leg and they happen to be on levodopa for their Parkinson's, then they're not getting the effect of the levodopa for Parkinson. Alcohol makes it worse. Alcohol, too much alcohol gives you ataxia and nystagmus. Same difference. Toxicity. Antidepressants. Well, one of the big things with elderly persons is they're depressed. And they can't sleep well. That happens anyway, but you get depressed then, and people recommend tricyclics because tricyclics old class of antidepressants, but they help sleep. Adverse effects of tricyclics, though, are little things like urinary retention, which old people complain about, particularly men. Constipation. All old people complain about constipation. And dizziness, drowsiness, dry mouth, blurred vision. Well, they already can't see because of their cataract. So, more problems. Anti-nauseant, if they're taking anti-nauseant medications, adverse effects are usually blurred vision and drowsiness, the effects of anticholinergic kind of effects. Gastroesophageal reflux medications, Tagamet, etc., Pepsid, etc. Adverse effects in the elderly, headache, drowsiness, confusion, psychosis, and hallucinations. Not to mention the fact that they adversely affect the uptake of a whole bunch of medications, including the anticoagulants, etc. Ventricular, all the antidysrhythmic drugs we give for ventricular dysrhythmias, cortisone, Norpace, they all have nasty effects of increasing heart failure, beta blocker type effects. Hypotension, tachycardia, interestingly enough, with cortisone, it's sort of a reflex. They get funny-looking skin, but blurred vision, constipation, difficulty urinating, all those wonderful things they get to complain about. Antidysrhythmic effects, antidysrhythm, Lenoxin, which is still prescribed in some elderly. Dysrhythmias, primarily heart blocks, and they get a yellow tint to their vision. Other Tambacor, which is another of the antidysrhythmic meds, both for atrial and ventricular things, worsens congestive heart failure, causes visual disturbance, dizziness, etc. Things you don't want. We get a lot of arthritic kind of complaints as we're getting older. Indocin, which is a wonderful drug for a 40-year-old, will just really knock down inflammatory things. It's sort of like ibuprofen on steroids. It's an excellent drug for severe inflammatory pain, but at the same dose that you would be fine, elderly people develop GI bleed from it. It completely knocks out the antiprostaglandin protection of the stomach, and you get GI bleeds, primarily ulcers. It causes depression, aggravates Parkinson's disease, causes fluid retention, edema, dizziness, headache, indigestion, all sorts of bad side effects. Elderly on antihypertensives, including Aldomet and Reserpine, which are pretty common drugs. Happily, we're getting away with those mostly to calcium channel type blockers, which seem to be better. Adverse effects of the antihypertensives, though, are edema, dizziness, weakness, orthostatic hypotension, very common, and depression and suicidal ideation with some of the antihypertensives. Inderol, commonly used beta blocker, causes fatigue, extreme fatigue in the elderly, respiratory distress, and aggravation of COPD and asthma. Now, type 2 diabetes. Common from about age 50 on, commonly treated with oral diabetic agents, diabetes, glucophage, and as you get older, you become less tolerant to these things, or there's less safety in it, and fatal hypoglycemia is not at all uncommon, which is why we tell you in your orders that, you know, if the patient is on oral diabetics or oral hypoglycemics, and they have a hypoglycemic episode, that is not a patient that you treat and leave at home. That is a patient you treat and transfer. Even if they say, I'm fine now, I'm going to have myself a snack, it's not a choice. They have to go in. They're going to have a rebound and a worse effect later on, and there's something wrong. There's something wrong with their dosing, something wrong with their metabolism at that point, other than just diabetes. So oral hypoglycemics, they get a trip to the ER for a full evaluation. Lactic acidosis occurs particularly with glucophage, and lactic acidosis may appear, the patient may appear to be ketoacidotic, although they turn out to not have any ketones. They will have lactic acidosis just like they were in sepsis. Acidosis is acidosis, so they do. But this is the effects of oral hypoglycemics. They get worse as you get older. Flexeril, Robaxin, things that people were taking when they were working, and they would get muscle strains and aches, have significantly greater effect in the elderly, including CNS depression to the point of near respiratory depression, dizziness, drowsiness, blurred vision, headache. Norflex, another non-narcotic muscle pain relief medication, is quite anticholinergic, and the effects of that at normal doses for you would be lightheadedness, dizziness, fainting, palpitation, urinary retention, constipation, which then they get to go to the next doctor and complain about those symptoms and get drugs for that. Narcotics. State of Washington last year, the number of deaths that occurred from prescription narcotics equaled the number of deaths that occurred from illegal narcotics. So the heroin and other deaths were evenly matched by the prescription opioid overdoses, most of which were, to the medical examiner, most of which were accidental, not intentional. But narcotics are out there, and there's some pretty heavy. You know, I'm always fascinated when someone will prescribe a patient some of the Duramorphs or the fentanyl patches, the 50 microgram fentanyl patches, and give them a prescription of 100. That's a lot of pain, but it's soon over, as they say at that rate. It's very easy for people to get overdosed on medications, and with the fentanyl patches, they misguess the effectiveness of it. So Demerol, Talwin, Darvon, Vicodin, all of the opiates, morphine. Hard to get Demerol now. Demerol has been vilified pretty much, but and so it's really hard to get it out of a pharmacy by prescription. But the Duramorph is very common, as is the fentanyl patch. Adverse effects, same adverse effects of any narcotic overdose, and it's more easily done in the elderly. We've seen elderly persons, you get called for alter level of consciousness all the time on people who have not taken anything out of their normal dose. Respiratory depression and arrest, worst thing. Bradycardia, hypotension, pinpoint pupils. Tolwyn, and I mean almost all the narcotics will cause urinary spasm. So patients are complaining of urinary retention often, particularly elderly men with any prostate problems. And obviously, you build up a dependence and a tolerance to the narcotic pain relievers. Herbal supplements, we're going to talk about briefly. Very popular. We spend $40 billion in the United States annually, which is not counted in the medical costs of the country. They're often listed as food supplements, so they're not under FDA control. No one has done a controlled study. There are very few scientific studies out there, although there is a small magazine devoted to scientific studies on herbal medications. For example, echinacea, which is commonly used for colds and things like that, when run on 2 double-blinded studies, had no more effect than placebo. So, side of the stuff makes me sneeze, so that's probably just as well to avoid it. But here's some of the kind of things that people are taking, and the reasons they take them, and what happens with it. St. John's wort. They take it for, it's touted to be for wound care. You put it right on it, and an antidepressant. I guess you don't care so much about your wound if you take it. Adverse effects, GI upsets, and if you're on a retroviral drug, for example, if you have HIV, it will interfere with the uptake of the antiretrovirals. Ginkgo biloba. People take it after they have a stroke because they think they'll get a better memory, they'll return to normal function. Take it after an MI, they think it makes your heart hurt. They take it for impotence, they take it for macular degeneration, and they take it for tinnitus. So it's kind of a general purpose drug. Adverse effects, increased bleeding, increased effect of anticoagulants. So if you're taking normal dose of Coumadin and your pro time is normal or is normalized where you want it, you take ginkgo, you get likely increased amount of bleeding. So if you fall down, bang your head, increased risk of intracranial bleed. Also causes nausea, vomiting, diarrhea, restlessness. So I guess you get up during the night, wander around, you fall down, bang your head, and bleed. Garlic. Garlic to lower cholesterol. Yeah. Blood pressure. It's good for your blood pressure. Anticoagulant, antibiotic, antiviral. You could give a whole clove of garlic to a horse. You worm it, So it works out pretty well for all stuff. Adverse, and you can also keep people away from you. Adverse effects: garlic odor, heartburn, gas. Guarantee. Can enhance. That's the So if you have wondered how come you're that way after you have a good Italian meal, that's why it's the garlic effect. Can enhance bleeding disorders or the effect of anticoagulants. A lot of people out there are on anticoagulants. Everybody with atrial fibrillation that hasn't been able to be converted is on Coumadin. Ginger. Really, ginger is allegedly good for nausea, in case you want to take some before we go out fishing on the ocean. Allegedly works for arthritis, however, it interferes with anticoagulants, causes CNS depression and dysrhythmias. Ginseng. Take ginseng to boost your energy, increase sexual stamina, reduce effects of aging, however, it makes you nervous, gives you a headache, hypertension, hypoglycemia. How does that affect sexual stamina? Well, marijuana, we know what it does. And now you can get unlimited amounts here and soon. But it does cause the munchies. Probably good if you know, if you were worried that grandma was losing weight and wasn't eating. You know, let grandma toke up a little bit, and she'd probably, you know, get right up to snuff. Melatonin. They take melatonin for sleep, and it's also touted to improve the intraocular pressure in glaucoma. Now, melatonin comes from the posterior pituitary extract. Although there are herbal forms of that. Adverse effects of melatonin: drowsiness, grogginess, sleepwalking, disorientation, makes, it says, nocturnal asthma worse. Okay, nocturnal asthma. You only get asthma at nighttime. Why? Sounds like sleep apnea almost. May increase the effects of other tranquilizers, and has a curious effect with magnesium, which a lot of people take magnesium supplements all the time. It's allegedly good for your heart. All the studies, by the way, have always shown that that supplemental vitamins and things like that, unless you have a known deficiency of vitamin B12 because you have pernicious anemia, all your supplements do is make more money for the companies that make the supplements. It doesn't do anything for you, no matter what you think. Valerian is used for sleep and sedation, improved sleep, restlessness and nervousness, causes palpitations, headache, irritability, grogginess, etc. Yohimbe, for impotence and erectile dysfunction. Now look at this one. Dizziness, insomnia, anxiety, hypertension, tachycardia, hallucinations, weakness, paralysis, effectiveness, antidepressants and antihypertensive effectiveness are reduced. I'm not sure how that's going to affect my erectile dysfunction positively. Grapefruit juice. Everybody loves grapefruit juice. You see those ads on, well, not everybody, but you see the ads on TV about how good it is for you. Yes, it is. But it inhibits two enzymes in the my mind is breaking up on it. It's isoenzymes that are integral to normal drug metabolism in the cytochrome P250 and 450 system. When you have these medications, then these medications are not metabolized through the normal process, so you get increased serum concentration, which gives you an increased risk of toxicity. Also increases the risk for drug interactions between the two drugs, and it will also decrease the effectiveness of certain drugs. So, if you are on, for example, Lipitor, Mevacor, Pravachol, the kind of the anti-lipid drugs, you're totally wasting your money to take if you're taking grapefruit juice. Now, a grapefruit doesn't have enough in it. So you could eat a grapefruit for breakfast, but a glass or two of grapefruit juice a day was enough to totally make your medications worthless. You will get increased effect of Xanax and the other benzos. You get toxic levels of erythromycin and antibiotic if you take this. Nobody gets Hismanol anymore, which was a drug that we used for. It was like Benadryl. But it's a super Benadryl. But what happened with Hismanol and grapefruit juice is it encouraged torsades because you end up with prolonged QT as an effect of the Hismanol effect being enhanced by the grapefruit inhibiting those isoenzymes. So a lot of fun up to this point. So why don't we take about a 10-minute break, and I can go refresh my memory. Let's run through some common medical problems in the elderly. Just like the rest of us, the elderly develop pneumonia, but they get pneumonia more frequently because you have decreased compliance of the chest, decreased compliance of the airway, decreased ciliary response, decreased ability to cough and get rid of viruses, bacteria, etc. by normal coughing. So with pneumonia, the patient may have typical symptoms, but frequently they're atypical because fever is often absent in the elderly, particularly if they're septic with their pneumonia. And pneumonia is the probably second most common cause of sepsis in the elderly. They may simply have a change in cognition, and a lot of times that goes along with sepsis too, so that if they're coming in from a care facility, their only complaint from the care facility is that they're not normal today or when they last looked, which may be today. Maybe just lethargy, shortness of breath, dusky, clammy skin. Pneumococcal pneumonia is the most common cause, generally after a viral infection such as the flu, and pneumococcal pneumonia accounts for somewhere around between 35 and 40,000 deaths per year in the United States. Pneumonia used to be called the old man's friend because they would slip away peacefully. Chronic obstructive pulmonary disease, chronic airflow obstruction. If it's reversible, it's really basically reactive airway or asthma type thing. Most of your COPD, though, is irreversible. Elderly patients commonly have both reversible and irreversible. And one form of irreversible COPD occurs from particularly older ladies who have they have an increased chest size, but it's fixed because they've gotten progressively shorter over the years as their osteoporosis in their vertebral body has allowed their spine to collapse and they collapse forward. The only way you can maintain lung volume, adequate lung volume, is to expand the chest, and so they get somewhat barrel-chested. They get a type of COPD not related to smoking, not related to being badly taking care of themselves. COPD is progressive. It's debilitating. When you can't even become a greeter at Walmart, you know that you're too short of breath. Pulmonary embolism from blood clots in the legs. Generally speaking, although little old men are at least a little bit more likely to develop pelvic venous thrombosis. Pelvic venous thrombosis is common in women of childbearing age, particularly after delivery or after surgery. Treatment of pulmonary emboli, oxygen IV. Obviously, the trick is to remove that clot if we can, if it's a large clot. Don't forget we had the one case of a cardiac arrest or a cardiorespiratory arrest that was successfully resuscitated and went to the cath lab to have the pulmonary emboli that had caused his arrest to occur. These are not entirely futile cases nowadays. So with good CPR, we managed to keep him alive to get him to the cath lab. Anticoagulants, patients will be put on anticoagulants for this. We could use IV TPA sometimes. If you have a patient who's you suspect pulmonary embolus, hypotensive, they may need vasopressors to maintain that. but we would not, it says avoid vigorous fluid therapy. I'm not sure with that. I think I would do a fluid challenge anytime too. Pulmonary edema, flash pulmonary edema is what we call when the patient rapidly develops acute pulmonary edema. And the most common cause of flash pulmonary edema is acute myocardial infarction. However, you can also get acute pulmonary edema from pulmonary infections, from toxins, narcotic overdose. So occasionally you'll see someone who's taken inadvertently too much of their prescribed narcotic, and they will have acute pulmonary edema. Pulmonary embolism and pulmonary edema can occur concomitantly, and if you treat one, now what's your basic treatment for acute pulmonary edema of whatever cause? What are you going to first treat them besides oxygen? Someone said last time. What are you going to treat the patient with? CPAP, if you can, or positive pressure breathing. Now, and nitrates if they're able to tolerate nitrates. If they're hypotensive, you need to get them not hypotensive before you can use nitrates. But CPAP usually does the trick. And then we treat the underlying cause. And we look for, anytime you have acute pulmonary edema, I want to see a 12 lead. Because that patient may have had an MI. Myocardial infarction. The elderly patient is less likely to present with classical symptoms. And you don't even have to be that old. We had a house guest a couple weeks ago that my wife had taught with in Minnesota. She's about 74 years old. And she had an acute myocardial infarction in January, and her only symptom was diaphoresis. She was cold and clammy and went, and that struck her as being odd. And her sister, who was a nurse, said, go to the emergency department. And the emergency physician said, you're just cold and clammy, go home. And they caught her at the front door because by that time her CPK and troponin had come back, and she was admitted and went to the cath lab and had a couple stents put in and all that sort of stuff, and she's fine. But I mean, her symptoms were simply diaphoresis. So, and that's particularly true of women, elderly women, but elderly men also don't. And if they've had a previous MI, they may not have any chest pain either. So the whole idea of anticipating acute coronary syndrome in elderly persons is we're looking for atypical signs and symptoms. So I always put a lot of faith in diaphoresis, as if you can't explain it. I put a lot of faith in unexplained tachycardia. To me, if someone has unexplained tachycardia, if I can't find a reason for it, it's got to be pulmonary emboli or medications, drugs. But anticipating persons to have, if someone has weakness, if they have an ache only in their neck or their back or their arm, and they have no chest pain, what's it cost to do a 12 lead? Nothing. And you're going to detect these people. Dysrhythmias are the leading cause of death in the elderly after an MI, just like they are for you. So if you have an acute MI in that first 2-hour period, you're at triple the risk for acute primary ventricular fibrillation. So, and we all know that time is heart muscle, so you can get a patient to the cath lab quickly. They go home. They don't have any major damage to their myocardium, which means they don't develop primary congestive heart failure after their MI, which means that you have just given them X number more years of life. Because if you develop congestive failure after a myocardial infarction, your 5-year survival rate is about 10%. Heart failure, not acute pulmonary edema, but heart failure is obviously when cardiac output can't meet all your basic demands. You have either impediment to flow, and so that could be due to vascular resistance. That could be due to bad valves causing congestive failure. Inadequate cardiac filling, so there's not enough preload, or preload is affected because of medications, so that you have volume, but you don't have enough volume. You have too much capacitance in your vessels. Volume overload, when you just have too much fluid, and that's really common, particularly if you take too much salt, too much everything, or you don't have adequate kidney function. Patients who have chronic kidney disease are going to end up with volume overload as a usual problem, and congestive failure ultimately. And then myocardial failure itself, where the heart cannot effectively produce enough power to have systolic emptying. So if you end up killing 15 to 20% of your myocardium of your left heart in a myocardial infarction, you will ultimately end up with irreversible congestive failure. You just don't have enough power then to empty the heart. Aortic aneurysms will be either thoracic or abdominal, characterized usually by tearing chest and abdominal pain. When somebody describes that they have a tearing feeling, a tearing kind of pain, any place in their back or even in their chest, you always suspect aneurysm. If it's in the ascending, if the aneurysm affects the ascending, if it happens after the branching of the ascending aorta, so that you get, it affects the left-sided carotids and axillary artery and not the right, then you'll get decreased pulses, decreased pressure in the left arm, and decreased pulses and pressures in the left leg. Now, generally, or both legs. We generally don't check the leg very much. We probably should do that more. We also don't generally check blood pressure. When I'm in the ER and I'm seeing patients with chest pain, I always have the nurses get right side and left side arm pressures. Every so often you'll find then that the right arm is 20 points or more higher than the left arm. That's kind of de facto proof that you've got an aneurysm affecting the flow into that arm, and it's after the right arm. Now, obviously, if your aneurysm is a type A-B dissection that's on the ascending, or all bets are off, because that's going to shut off the flow to both sides of the body. But and the trick with that particular dissection is those are also highly associated with sudden cardiac arrest and myocardial infarction, because they dissect downward from the ascending aorta and occlude the right or left coronary artery, which is kind of a guarantee for a myocardial infarction on top of a dissection. Abdominal aneurysms, you may feel pulsable masses, you may may not. You may just have hypotension if it's actually ruptured. So tearing pain following or preceding an episode of shock kind of is indicative of a dissecting aneurysm. Now, blood pressure, management of aneurysm. If you think you have a thoracic aneurysm or even an abdominal aortic aneurysm, and the patient is hypertensive, as they often are to start with. They'll be hypertensive in one arm or the other. The goal is to reduce their pressure into the 90 to 100 range to keep the dissection from going any further. Once you rupture and you're in extreme hypotension, then your only answer is fluids. You may need pressor agents at that point too, but the answer to that one is to go to surgery as quick as possible. So that's a rapid trick, maintaining pressure as well as you can. But as a general rule, for most thoracic aneurysms, we now treat them not by surgery, but with medication, with maintaining blood pressure in the low normal range to reduce the dissection. I've had several patients who have been doing well with medical management of their dissecting thoracic aneurysm for 10, 15 years. They recanalize, and they have, and one of them, I remember, has 4 or 5 channels through the aorta that are, she's maintaining perfectly well. But these are extremely difficult to operate because of the spinal perforating arteries that come off the thoracic aorta, and when you cut those, you cut the flow to the spinal cord, so the spinal cord is dead from that point down, and you end up with paralysis. So that's not a good trade. So we found that medically you can manage the people just by keeping their blood pressure okay. Now, I'm sure that they won't last as long as someone without an aneurysm, but until we come up with a better answer. And now they actually put stents in too. They're floating some pretty big stents into these things. So it's intervention, but it's intervention by a radiology intervention. Hypertension is sort of arbitrarily described as blood pressure greater than 140/90. Well, I just read a new article that seems to indicate that if you have a blood pressure of between 90 and diastolic 90 and 100, and you don't have any symptoms, that maybe treating it is worse than not treating it. But arbitrarily, we've decided that blood pressures are 140/90. That's the current internal medicine thing. Your blood pressure should increase, at least your systolic, and to some extent your diastolic, increases with aging, with atherosclerosis. Obviously, obesity and diabetes is highly related to this. And frankly, most people don't have symptoms until they get into systolic blood pressures in the 160 to 180 range, and diastolic well above 90. Non-specific complaints related to hypertension include headache, tinnitus, ringing in the ears, epistaxis. Epistaxis is, once again, is, as I've always said, is primarily related to hypertension in your index finger, because it's usually what causes the epistaxis. Then you can't stop it because of the hypertension. Some patients with hypertension get a slow tremor, but most people with tremors have other neurologic things going on too, such as Parkinson's disease. Patients with hypertension may have nausea and vomiting. So they're all kind of non-specific symptoms, and we just treat it symptomatically. You treat it, your orders are pretty specific for hypertensive emergencies. If you have a severe headache without localized focal neurologic findings with a systolic pressure that's markedly elevated and a diastolic pressure over 120, bring it down with nitrates. Bring it down with nitrates. You could use some Lasix at that point too, but it probably won't affect much at that point. Syncope occurs when, for whatever reason, blood flow to the brain is temporarily interrupted or decreased. Now, you get vasodepressor syncope, which is basically vaguely mediated. You get a slowing of the heart rate and a drop in the blood pressure, so that temporarily decreases blood flow. Most people can tolerate absence of blood flow for, amazingly enough, for like only 3 or 4 seconds, which seems strange because, you could, think that'd be longer. But orthostatic syncope generally occurs in related, very commonly in the elderly, particularly when they're on antihypertensive drugs, when they're on diuretics, and so they further reduce their already reduced blood volume, and so they don't have the ability to adjust to changes in position. So basically, it's like doing a tilt test on them every morning when they get up. Cardiac causes, some people, they can be everything from second degree, third degree blocks to intermittent blocks to momentary pauses in the normal pacemaker. You get a sinus pause, and like I say, 3 to 5 seconds will drop someone as a rule. They also have things that are called drop attacks, which we don't entirely understand. They're probably neurologically induced vasodilatations, which cause a sudden drop in your blood pressure. Now, don't forget that syncope and seizures can often be confused. And a lot of times, if you faint, if you have a syncopal episode, people will have 1 or 2 beats of basically anoxic. It's not a real seizure, it's just a couple of tonic-clonic jerks. Not everything that jerks is simply a seizure. It could just be a result of that. Transient ischemic attacks occasionally present as syncope. Now, cerebral vascular disease, strokes, symptoms vary. Altered mental status, coma, paralysis, slurred speech, change in mood, and seizures. So, sometimes after a seizure, if someone has a known seizure history, they will wake up paralyzed. This is a transient thing. It will last for hours to days. But obviously those patients are not, those are the ones we very carefully work up to see whether or not that was a stroke followed by a seizure or a seizure followed by stroke symptoms. Now, you're going to do the FAST screen. Look for asymmetry of the face during a smile. Now, it helps to have family there or someone who knows this person because they may always have had a crooked face, a crooked smile. Look for arm drift. Arms out, one drifts away. Speech. The sensical repeat of a simple phrase. That tests 2 things. First of all, whether their motor function and their speech function is there, or that was knocked out, or whether they can understand what it is you said. And then you establish the time last known normal. Now, all of those things don't, well, you always have to get the time, but you may only have asymmetry of the face, arm drift, or speech. You don't have to have all three, obviously. Now, under our orders for this county, we transport code 3 emergent if it's less than 8 hours onset. Now, where they go is going to be a little different. So, but the symptoms we're looking for are aphasia, that you'll establish by their speech, facial droop, unilateral weakness or paresthesia, inability to understand, loss of vision in one eye or visual field, vertigo, sudden onset, persistent, progressive vertigo with a headache. Now, vertigo is one of those hard things, and if you over air, I'm fine with that. Vertigo, true spinning dizziness, is a little different than ataxia, which is the inability to walk in a straight line because you're losing your balance Now, ataxia is often associated with drugs or with a posterior or cerebellar-based stroke. But ataxia is sometimes confused by the patient. They say, I'm really dizzy. What do you mean? Are things spinning around? Yeah. But they're really not spinning around, but that's their understanding of it. And they may also be confused by the whole situation. Now, the most common cause of vertigo in the elderly is the same as the most common cause of vertigo in you guys, which is acute labyrinthitis, which is probably a virus, maybe a virus toxic kind of thing, but your inner ear mechanism is messed up. But if you're older, you're more it's more likely that stroke is a possibility. Now, vertigo with a sudden headache in any age is indicative and worrisome for a subarachnoid hemorrhage, an aneurysmal bleed. We also transport emergently now if the patient went to bed normal and woke with symptoms. You say, well, gee, it was 6 hours ago or 8 hours ago that he went to bed, so we don't know when the stroke happened. Well, it turns out a lot of these strokes happen just before they wake up and happen to be the thing that wakes them up. So those patients can get transported to Southwest because we will still go through the whole process and probably take them to the cath lab if that's indicated.
So can we only take them to Southwest if
Yep.
they woke up with symptoms?
Mm-hmm. Yep, right. They're not accepting them yet at Legacy. So obviously you activate the stroke team. What that does now is you get the physician, the ER physician, to immediately evaluate the patient within 10 minutes and see whether or not they will do what's called a neuro 911. During the day, the nice thing is the stroke physicians are right there. They'll probably see the patient as you come in with your code 3 stroke. Otherwise, a neuro 911 will be called, which pages out the entire team. Now, patients who meet stroke or CVA criteria get transported as follows. If their symptoms are 3.5 hours or less, that means we can effectively treat them with IV TPA if it's indicated. If they pass the CAT scan test with no bleed, if they pass the other thing, and we stabilize their blood pressure. Those patients for IV that could have IV TPA could go to either hospital, the closest stroke center if they have no choice, if they have no preference, or to the hospital of patient preference. Now, if they're more than 80 years old, however, those patients will only be treated with intervention, usually with intra-arterial TPA put right on the lesion or with an extraction of the clot with a Mercy type extractor or one of those things. Those go to Peace Health. If their symptoms are between 3.5 and 8 hours or they woke up with it, they go to Peace Health because those patients, by definition, are going to need interventional treatment, if anything. 3.5 hours is too long past the time to get IV TPA. That's why they go to a place where they can get intra-arterial TPA or an interventional treatment. If you think they have a suspected intracranial hemorrhage, whether it's bleeding and they're comatose, and that's, it should be pretty obvious that they're comatose, probably from a stroke. They may have hypertension, they may have slow heart rate, they may, Cushing's triad kind of stuff, erratic breathing. They're clearly not waking up to your treatment. Or they have the sudden onset of worst headache ever, or sudden onset of headache followed by weird, unusual neurologic symptoms. Those are intracranial hemorrhages, and they need to go where the surgeons are. And the neurosurgeons are 24/7 at Peace Health. Dizziness. Well, we already talked about it. I don't have to talk too much more. Dizziness is often accompanied by sweating, pallor, nausea, and vomiting. They look terrible. They feel terrible. Meniere's syndrome is recurring episodes of one-ear tinnitus associated with extreme vertigo, vomiting. They feel terrible. They will feel a little bit better. You can give them anti-nauseant meds. They sometimes, interestingly, feel better with mild sedation. But I would call and ask for that. I mean, if you have someone just retching in the back of the thing, give them, start out with your usual anti-nauseant, and then you can go to anapsine. But they get quite they'll hurl across your rig. Okay, dementia, delirium, Alzheimer's disease. Dementia is chronic, global cognitive impairment. Progressive, usually irreversible. Delirium is global mental impairment of sudden onset. So, delirium is chronic. Delirium is rapid onset, dementia is chronic. Delirium can be reversed if treated early. It's usually due to something. It's due to a toxin. It's due to an infection. It's due to a head injury. It's due to a metabolic change. So it can be reversed if you catch it early enough. Dementia, you can't reverse it. You might slow it, but you can't reverse it. There's nothing out there I know that right now that makes it better, but it kind of slows it. Global cognitive deficits in dementia, focal, often in delirium. So, if you have a choice between delirium and you don't know, is this patient a delirium patient or are they a chronic dementia? You're better to err from the emergency standpoint on the side of delirium, because we can treat delirium if we find the underlying cause. You really can't do much with dementia. Alzheimer's is a chronic form of dementia. It's a degenerative disorder that attacks the brain, impaired memory, particularly recent memory, ultimately all memory, thinking, and behavior. The first thing to go, though, is the last thing you knew. So they won't know what they had for breakfast. They don't know you were there, but they remember their little sister from the time that they were like 8 or 10. And then after a bit, they forget about little sister too. Parkinson's disease, nasty disease, degenerative disorder, affects primarily the basal ganglia of the brain, but it results in changes in muscle response characterized by tremors, loss of facial expression, and gait disturbances. The tremor is often a pill rolling type of tremor. Pill rolling, you know. What do you guys know about pill rolling? I mean, pill rolling is something that used to, they call it pill rolling because pharmacists used to make pills by rolling the stuff together to make pills. So that's what the pill rolling is about. It's this kind of a thing where you kind of roll your thumb over your fingers. So this is the kind of tremor they have. It's usually a slow tremor, and it's not intentional to start with, so that if they want to do something, they'll reach up for it, and they'd have no tremor doing it. Ultimately, they will get an intentional tremor as well, and it's hard for them to hold things. And then the muscles of the arm and leg become progressively more rigid, and their movements are jerkier. So they develop what are called lead pipe extremities. And lead pipe is another thing. You guys only know about plastic pipes because you don't make, except in Europe and really old houses here, you don't have lead pipes anymore. They used to make lead pipes, use lead pipes for plumbing because they were bendable. But they're bendable in a very specific thing. When you bring them out, it gives progressively. It's a lead pipe. So, and then when they walk, they shuffle because they lose the sense of, and their movement, they're shuffling, they're often leaning forward. They're now and because the facial muscles are affected, it's very flat affect. I have a good friend who, he always looks unhappy. He's not unhappy. He has Parkinson's disease. He's unhappy about that, but now, the ultimate progression of Parkinson's disease is that the muscles of respiration and swallow are also affected. So as they get progressively older, they may have difficulty swallowing, eating. They may have lots of difficulty with aspiration. They will and respiration, and they will ultimately probably die of a respiratory infection or relative respiratory paralysis. And a lot of times Parkinson's ends up with a Parkinson's dementia. And it's totally unpredictable kind of how that. Now we treat it with a lot of medications, levodopa and other things, and to lesser, those have side effects, those have complications with other medications, and it's just we don't really know why people develop it. Chronic neurologic things like this are not perfectly explained as yet. Diabetes mellitus, type 2 diabetes is more prevalent in elderly patients. Well, you have to be over a certain age to have type 2 diabetes. And the initial stage, very seldom do the elderly present with the first time diagnosis of diabetes. They don't present with a ketoacidosis like younger persons do. They may have just fatigue, weakness, and you find that they have elevated glucose. They more commonly develop hyperosmotic, hyperglycemic coma rather than diabetic ketoacidosis. So you'll get a glucose of 800 to 1200, and they will be not ketotic at all, but they'll still be very hyperosmotic. Their problem is all osmotic. Management of diabetic and hypoglycemic emergencies is the same in elderly adults as in a normal adult or a not elderly adult, in that you manage hypoglycemia with generally D50, although stay tuned because in September we'll bring you the D10 treatment, which is much more scientific and works out better. And also we can get D10. We ran out of D50, Kind of interesting how I guess the sugar beets are not available anymore. And then diabetic, whether you think the patient is ketotic or they're simply hyperosmotic, it makes no difference. Those patients need fluid for their coma, their treatment for hyperglycemia. Fluid, fluid, fluid. Okay, GI hemorrhage, very common in elderly. Upper GI bleeds are primarily caused still by peptic ulcer disease, develops in the elderly, or by gastritis. Now, occasionally you get esophageal varices, but you should probably be able to sort out that that's in a chronic alcoholic who has signs and symptoms of ascites, probably has other symptoms of chronic liver disease. A Mallory-Weiss tear is occasionally a tear through the lower esophagus. Lower GI bleed, the number one cause is diverticulosis, followed by tumors, AV malformations. Signs and symptoms. You know where it is by what you get. If you get coffee ground emesis, that's blood that's been partly digested. It's been exposed to stomach acid so that your iron has gone from ferrous to ferric, and it's now black in color and a little chunky. So that means upper GI bleed. You have bright red blood vomiting, obviously upper GI bleed. Could be Mallory-Weiss then, or could be esophageovaric. Black tar-like stool means upper GI bleed, because this is partly digested and digested blood that is now turned black and gooey because it's been partially digested, and the iron has been turned into the black color. If they have obvious blood in the stool, red blood, whether it's venous red blood or bright red blood, it's lower GI bleeding, because there's no stomach acid acting on it. It hasn't turned that red hemoglobin black. Obviously, the things you want to check is orthostatic hypotension. If they say they're dizzy, don't stand them up. Take their word for it. If their pulse is greater than 100, if their pulse is only 60 or 80, and you say, oh, they can't think of beta blockers because they're beta blockers, just like any other patient who is anticipated to be in shock and then to have a low heart rate, that's probably a beta blocker. Confusion is one of the best signs of shock in older adults. Bowel obstruction typically involves the small bowel in elderly persons. A patient will usually complain of diffuse abdominal pain, bloating, nausea, vomiting. The pain may be intermittent, coming and going as the intestine is cramping. They may have fever, weakness. The usual causes of small bowel obstruction, tumors are down the line. The usual causes are infection and or adhesions from previous surgeries. Always look at a belly. If you have a virginal belly, it's uncommon. They're uncommon to have bowel obstruction. Patients complain of itching a lot. This is usually caused by not taking care of their skin very well, or dermatitis. Older people get severe eczema as they get old. The skin dries out, thins out, and then they get psoriasis and seborrhea, and a common dermatitis is eczema. But they're a bit more susceptible to bacterial and viral infections. This is a picture of herpes zoster, and it's involving a large portion of the fifth nerve, which was a particular emergency because it has to be evaluated to make sure that the eye is not affected, because the cornea can be infected when the fifth nerve is infected, and you end up with corneal ulceration, blindness, little things like that, which is not good. This should have been treated long ago. This is an easy one to treat. Most of the time, herpes zoster shingles presents as, unusual pain in the side or in the arm or the side of the chest. It has been confused with cardiac disease. And then when you go to put your 12 lead on, you see this rash in one spot on the chest. You say, oh, aha, and take them right to the cath lab. Herpes is perfectly treatable nowadays. It's also preventable. We try to give us old guys shingle shots, which is the same as the chickenpox vaccination. Decubitus ulcers, you see those in people who lay in one place. Highest incidence, of course, is in nursing homes where the patient should be changed, should be rolled over. They don't have eggshell mattresses, and they get, where the bony prominences are, they get ischemic compression of the skin and subcutaneous tissues, including muscle sometimes. And those are terrible to treat and terrible to cure, because part of the problem is how they got it in the first place. That's going to continue to, they're going to continue to roll on that if they're not moved. Inflammatory arthritis, very, very common in the elderly. Ankylosing spondylitis is a type of rheumatoid, so it's an autoimmune type of disease. Primarily affects the spine. And it's generalized. If it infects the entire spine, they develop what's called a bamboo spine, which means that their spine just doesn't move at all. It's rigid. We every so often see an occasional person who has ankylosing spondylitis of several levels of the spine, but not the entire thing. But the fused spine, if it's cervical spine, is extremely fragile, subject to fracture, and it's going to affect how you manage that patient if you're using airway techniques, because you can't move their neck, for example. It's going to affect how you're going to transport them. A lot of people who have severe ankylosing spondylitis of the thoracic spine cannot lay down flat because they cannot breathe adequately if they're laying down flat because of their spine. So you have to take that into consideration when you package and transport the patient. A couple things contribute to renal disorders in the elderly. Number one, your kidneys decrease in size. Not only do you get shorter, your kidneys get smaller. And then there's changes in the wall of the artery, atherosclerosis of the artery, so they do not filter as well and reabsorb as well. So patients are likely to develop, about half of the elderly people that we see have, if we wanted to write them up, they have borderline chronic renal failure, which means their creatinine clearance levels are high, the creatinine level is high, their BUN is a little high. All the tests that we do of normal kidney function means that they're right on the border of going to kidney failure. They're not yet, they don't need dialysis. They're not in renal failure yet. They're not going to get into toxic levels, but they can be kicked over by injury, by shock, by infection, and very easily go to chronic and acute renal failure. Now, urinary tract infections by themselves are most often caused by bacteria and lead to urosepsis, which is a term that we don't like to use much anymore for a number of reasons. But for you guys, urosepsis, and what this means is most of the time when we see septic patients coming out of nursing homes, it's because they have a urinary tract infection. They have chronic renal failure, they have chronic stasis of bacteria and urine in the bladder. They may not be emptying their bladder effectively, and they ultimately get the bacteria swim upstream, infect the kidney, and then get into the bloodstream, and they get septic from that. It's gram-negative bacteria, usually E. coli and bacteria like that. And their symptoms are, grandma isn't her normal self today, she's not eating. Take her to the hospital and find out what's wrong with her. And by the way, yes, she always smells bad too. Because they smell like urine. They don't have urinary, these little old people laying in bed like this, you know, they don't have urinary tract complaints. Urosepsis, may have fever, probably won't. May have chills, or if they did have fever and chills, it was missed because it was transitory. They may complain of abdominal discomfort, but the usual thing is decreased level of consciousness, plus or minus elevated heart rate, plus or minus elevated respiratory rate, plus or minus decreased blood pressure. Any two of those are symptoms of sepsis when you have two of them together, and big suspicion. So it's whole diagnosis and treatment of sepsis has gotten a lot of press recently. We'll probably in the fall talk a little bit more about that. There are a couple of things I'd like to add to your ability to determine whether someone is septic, but we're waiting for a appropriate pre-hospital test to come out. They're testing the material right now. Basically, it's checking the lactic acid. I'm going to be very quick about this because we've spent a lot of time on it. Just like children, the elderly are at higher risk for extremes of temperature too, either hypothermia or hyperthermia. Problems with hypothermia is that elderly patient cannot often respond to cold by shivering. They don't have enough muscle activity to shiver. Now, this is aggravated by medication. It's aggravated by things like concurrent diseases like diabetes and Parkinson, thyroid disease, etc. Non-specific signs and symptoms for hypothermia: slow speech, confusion, sleepiness, bradycardia late. Obviously, the thing to do is, one of the other things that contributes to the development of hypothermia in the elderly is they cannot, after the age of 60, you cannot tell the difference in temperature in a room for about 2 to 3 degrees. So you may think it's 70, but it's really 67. You can't tell. Now, younger people can tell 1 degree difference in change on the skin, but us, old guys can't. Now, hyperthermia, there are age-related changes in your sweat glands, so they don't work as well. You can't modulate your temperature by sweating. There's increased incidence of heart disease. There's increased medications for your heart and for hypertension and all those things that will affect how your sweat glands react and how you respond to heat changes. Temperature is the best indication of hyperthermia. Theoretically, anybody with a temperature over 104 is heat stroke. But it's also, the best test is your mental status again. Substance abuse, rampant in us old guys because we have all of these things listed on this stuff that contribute to this. This is basically related to elderly depression, but there are age-related changes in your body and your ability to metabolize. You can't handle alcohol like you used to be able to, even though you're theoretically used to it. Employment loss, loss of a spouse, multiple prescriptions, malnutrition, loneliness, being in a care home, signs and symptoms of drug abuse are pretty global. Memory changes, drowsiness, decreased vision and hearing, orthostatic hypotension, people who have chronic falls at home always have to be that always has to be reviewed to see what medications they're taking and how much alcohol they're doing. Poor dexterity, mood changes, falling, restlessness, weight loss, all the things that sound like being old. And then it's just aggravated by substance abuse. Alcohol puts us at risk for toxicity for all the other drugs. Now, psychological disorders relating to age are organic brain syndrome, of which many people lump Alzheimer's and dementia into organic brain syndrome. It's kind of a catch-all. Depression, a dependent personality. Can't be left alone. You can't, sort of the problem for the family to take care of you then. And often paranoid disorders. If they were a little bit anxious as young adults, they get very paranoid about their own safety mostly. And your emotional well-being affects your physical health. Now, this is an interesting geriatric depression scale. This is of course, you have to be able to read it to check it, but it's. I took it, and I scored at least 5 or 6 on this, but then I was kind of bothered by some of the questions, like, how would you like to answer this question? Do you feel pretty worthless the way you are now? I mean, do you hope you die horribly? These are extreme. I don't know who wrote this one, who came up with this, but it made me depressed when I read it. Symptoms of depression: sad, feelings of despair. You may have had some past psychological treatment, current stressful event, hypochondriasis. Depression is the leading cause of suicide in the elderly, of course. There we go. Hot rodder. Okay. Trauma is, I don't think it's is a leading cause of death in the elderly. And we have shown that over the last 12 years, in the statistics from the state of Washington show deaths from all forms of trauma decreasing at all age groups, except for the elderly, where it's increasing. And the number one cause in the elderly is falls. And they're ground level falls, because the elderly are not generally climbing on top of buildings or rocks to fall off. They're just doing ground level falls. Contributing factors would be osteoporosis, reduced cardiac reserve, so that when you go into shock, you have much less likelihood of surviving that. When you go, or more likelihood of developing shock from a minor blood loss. You have a problem with renal failure developing due to shock when you're in a trauma situation. Decreased respiratory function, so you cannot, even under high flow O2, you don't oxygenate as well. Blood pressure, pulse readings are deceptive, particularly in the elderly and in children. So, and also the elderly, perception of pain is decreased. So, once again, the best indicators of, or predictors of shock in the elderly is altered mental status. Geriatric abuse, just like child abuse, occurs. Signs and symptoms, just like child abuse. Unexplained injury, injuries of multiple ages. Pay attention to the inconsistencies of the caregiver, whether it's the spouse or a regular caregiver. Don't confront, but document and report this to the nurses, just like you would a child abuse case, and we'll get an adult evaluation for elder abuse out there, However, it's a little slower than child abuse in this community. Transport can, when you have just to reiterate that you have to modify the position, immobilizing, and packaging of the patient, the trauma patient, based on the other factors that are going on. If they have arthritis, if they have kyphosis, if they can't lay down, if they say if they have COPD and you can't lay them flat, you have to position them in a semi-Fowler type of position. There are the increased risk for developing hypothermia, so just like with infants, keep them warmer, keep them warm. Orthopedic injuries, they're sort of order of magnitude. Most common fractures, hip and pelvic fractures from ground level falls. Proximal humeral happens from falling straight forward, just like distal radius happens from falling in an outstretched hand. Proximal tibia, and if you get a distal radius, you often get a proximal humeral at the same time. Proximal tibia is easy to go, and then thoracic and lumbar bodies are always compressing, sometimes even without apparent injury. I mean, a apparent real cause. If you sit down fast or hard in this chair, I've had people collapse a couple of vertebrae. They can be fixed now. Burns, risk factors are they get burned a lot because they're not very good at cooking anymore, taking care of stuff. And they're increased risk of shock from smaller burns because they get renal tubular damage more easily, and they need adequate fluids. This is not a problem most of the time. The adequate fluids they need, don't worry about trying to memorize the Parkland burn formula and all that. And there's a geriatric Parkland burn formula too, which makes it even more ridiculous because it's the hospital that has to worry about that 24 hours of initial fluids, not in the field. You don't want to bring them in overloaded, and most of the time we get about 500 cc's of fluid maximum into anybody anyway. One of the things that protects your brain from a fall also makes it more at risk. As your brain begins to decrease in size and volume as you get older, and so you having a little bit more fluid around it, but that allows your brain to waggle back and forth a little more likely and cause subdural type hematomas, which are more common in older adults from the same fall. Plus, patients are often on anticoagulants. Big factor now. One of the new anticoagulants we put on the difficulty with it, we cannot reverse its effect. We can reverse the effect of Coumadin with vitamin K and with fresh frozen plasma. We can't do that with some of the new ones. Cervical spine is more susceptible to injuries due to osteoporosis, spondylolysis. And then if you get arthritic changes, as you develop arthritis in the neck particularly, this causes a nerve compression often, so they develop chronic pain and wasting in their arm. We saw a patient not just the other day that had slowly developing weakness in an arm from simple arthritic changes in the neck and end up with what's called spinal stenosis. But because of money, because of lack of adequate insurance coverage, avoided doing anything about it for 2 years. By that 2 years, the nerve roots that are compressed are now compressed. They're dead. And so that won't come back, even with getting fixed. All right. Well, that's a quick trip through old la-la land of us old guys. Now I'm trying to find my thing for today. Okay, I've got a couple of We got some case reviews. Got 4 case reviews today, which we should be able to burn through pretty quickly. Okay. No jokes? Okay. Case 1. These are all cardiac cases today. Upstairs apartment, 32-year-old female supine on floor, unresponsive, pulseless, apneic, family doing CPR. Family states patient was in the kitchen, heard a thud, came in, found her on the floor, unresponsive, not breathing, started CPR. No complaints prior to the incident, denied any medical history, medications, allergies, drugs. Unknown if patient had had during fall, etc. 32-year-old Hispanic female, 120 kilos, unresponsive, pulsive, apneic. Initial EKG after 2 minutes of CPR, asystole. Blood glucose 355. CPR done, BVM, defib pads attached, CPR continued, asystole. Checked for peripheral IV sites, found none, started an interosseous left tibia, gave epi, followed by a flush, 2 milligrams of Narcan, orally intubated with a 7.5 tube using King Vision, confirmed waveform ETCO2, continued in asystole, and got another milligram of epi, then noted to have a supraventricular rhythm and had a corresponding pulse. CPR discontinued and BVM continued. No blood pressure. Got 400 of fluid challenge, carried downstairs to gurney. Tube placement confirmed. So this is good documentation of tube placement every time they move the patient. Transported, glucose check, dopamine drip had been started. Finally, a blood pressure of 64/28. Patient remained in sinus rhythm. Okay, so she's admitted to the CCU hypothermia protocol. Levofed was necessary for blood pressure support. Dopamine wasn't managing it. Patient has severe anoxic encephalopathy. I thought her arrest was due to an arrhythmogenic cardiac condition, but they had no unknown cause. They're not going to work anymore. Prognosis is poor. The last I knew, she was still maintaining, but I suspect that will not happen entirely. At the very least, she is not, with severe anoxic encephalopathy, she'll always, she won't be a candidate for any further intervention, nor will she, but the case, was handled well. Everything was done. Sometimes the magic doesn't work. Okay, this one's a 67-year-old female. AMR's doing CPR, initial rhythm asystole. Patient's son did CPR before arrival. Downtime's unknown. History of hypertension. So her initial is asystole. Continues in asystole. Goes along with gets IV, gets epinephrine, intubated, CO2 and waveform. CO2 is 45, not bad. Now, it goes about this point, goes to ventricular fibrillation. She gets shock 1, defibrillation. Get some more epinephrine, continue CPR, gets the fib again, so she gets shock 2. Okay. Now, she gets rock ALP study 1A and 1B, gets defibrillated, gets epinephrine again, Now she has sinus bradycardia, no pulse, gets some dopamine and dextrose, systolic blood pressure, no blood pressure, pulseless, continues with chest compression, continues with basically a PEA, and this goes on to continuing to literally to PEA throughout the whole thing, and then ultimately called. And her, they're at it for an hour, and her CO2 is 33 still. They're doing really good CPR. So this was a good rock study. Everything happened right on the thing. This goes on forever, and did not work either. This is about a 29 or so year old guy. Patient's wife stated he's not seen a doctor in years, taking no medications. He's in a cardiorespiratory arrest. On arrival, she's unaware of drug allergy. Patient purchased a CPAP machine to help him sleep better at night. Now, this is the ultimate in self-medication. You're going to buy your own CPAP. But this is also kind of interesting because ultimately we do diagnose this guy as having sleep apnea. And sleep apnea is one of the things that's associated with sudden cardiac arrest. So, wife spoke to patient approximately 30 minutes before. So we didn't know when he'd gone down. 150 kilo. I think I found the reason for sleep apnea. Unconscious, unresponsive male. CPR in progress by police department. AED, police department AED attached to the patient. They're already given one shock. They're on the second round of chest compressions. Skin's warm, pale, diaphoretic. Chest defibrillation patches in place. Extremities unresponsive. AED shock delivered. Second, so they had it on already. They're finishing it. After he completed second round of chest compressions, strong radial pulses times 4. Sinus tachycardia. Respiratory rate less than 8. So we gave Narcan, unchanged. Did a 12 lead. He has anteroseptal STEMI, anteroseptal inferior STEMI. He was RSI, etomidate, succinylcholine, choline, and then they couldn't learn. They couldn't pass the tube with the regular laryngoscope. Switched to the King. Monitor failed. Attempt, that's the second one we've had now fail. Attempt with an Eshman catheter unsuccessful, so they placed an iGel. And when they placed the iGel, they put the ET-CO2 waveform on, and he has positive UTFC, so it's perfect. They're managing airway fine. Versed given with diminished movement, transferred now by TARP downstairs. Cardiorespiratory arrest with ROSC and STEMI. Informed the hospital, began cooling at cold packs because they couldn't get another IV line in to start the hypothermia. Here's his resulting 12 lead. Yeah, even through this it looks bad, right? Okay, so in hospital he had another VFib arrest, but was resuscitated. He went to the cath lab. He had curiously nothing that had to be really replaced. And their question then was, okay, do you qualify to get? So he didn't have any stents. Did you qualify to get an AICD? And they basically, he's survived this thing and he's doing okay. And they said, okay, are you going to, we don't think you'll fit the requirements for an AICD. They're about, by the time you get done putting it in, it's about $100,000. Yeah. So They said, you can wear one of these vests. Remember the vest lady came last? Okay, and he said, this doesn't, I'm not even sure I can get a vest on. So he said, I just want a AICD. So they put one in. And of course, he also had diabetes, he had hypothyroidism, and he has sleep apnea. But he's discharged, so 10 days after his cardiac arrest with CPC of 1, which means he has no apparent neurologic deficits. So perfect case. Would have been a nice rock case, except he didn't fit the rock thing because he came back with pulses. The other interesting thing about that is this happened this was Washougal Police Department, as I understand it. Camas police pulled their AEDs off the day before because they said, we never use these things. We'll have to get them back on. Dispatched for another cardiac respiratory arrest, 54-year-old patient's brother's performing good quality CPR, has past history of cabbage ×2, hypertension, multiple back surgeries, etc. CPR is initiated, 3 shocks given, AED mode by the BLS crew, life pack put in manual mode, he got a milligram of epi, he got ALPS 1A and 1B immediately after getting the epi, so they got it right in as quick as they could. And they got ALPS 2 5 minutes after ALPS 1. He continued in VFib, ultimately went to asystole, and ultimately code was called. But this was another good, this is where they had 3 shocks in rapid succession and immediately get the epi and the ALPS together so that, as soon as possible. This is the physio control dashboard on this one. The only thing of interest in this one to look at, and this is, I think this was probably the initial life pack, and we'll probably have to go back and your CPR ratio is a little low. We like to see the CPR. What that means is the amount of time you're actually on the chest. And so this probably means a little bit. It's probably because it was in AED mode for a whole bunch of the time. And so they had X amount of time for the, every 2 minutes they'd have maybe 10 or more seconds for the machine to analyze. So that makes it more, so we really like to see it pegged about 90%, so that means you only have about 10 seconds off the chest in a 2-minute period. And also the compression rate, the compression rate is good while they're doing compressions. I mean, it's a little fast, and their compressions per minute are about 90 when you add in all that time off the chest. So when you go to teach your BLS people, get them to practice running a complete AED mode thing so they get back on the chest while they're waiting for the machine to charge up when they put the charge button. Okay, don't forget. So all of the ALPS things were done well this time. Now, that way I don't have to meet and be mean, because I have enough steroids on board right now to be really mean. ALPS inclusion, I'm just trying to pump up, ALPS inclusion criteria: non-traumatic out-of-hospital cardiac arrest with vascular access, with persistent or recurring VFib or VTAC after 1 or more shock. We can't use any open label amiodarone or lidocaine, any hypersensitivity to amiodarone or lidocaine, which almost nobody knows. Protected populations are out, prisoners, minors, etc. Those are the no study bracelets. Anybody seen a no study bracelet? I haven't either. What counts as a shock? Any shock given either by a ROC EMS agency, a first responder BLS AED, a non-ROC agency first response AED, any ALS giving a shock, any public access defibrillator non-ROC agency shock. In other words, any shock given by an AED or an ALS agency counts as the first shock. So that means if they're still in VFib after that shock, they are in recurring or refractory VFib. ICD shocks are the only ones that don't count. So any confirmed VFib, pulsative VTAC, and it's confirmed if an AED shocks it. Take it to the bank. That was VFib. If then, at any point in your treatment, you're thinking antidysrhythmic drug, then you are now going to give the ALPS drug, because that is your antidysrhythmic drug for the study. Study drugs have to be given as soon as possible. Like in that last case, they came in, it's delayed. They've had 6 minutes at least, plus probably 5 minutes or 4 minutes for the first responders to get there. So they're at about 10 minutes, and they immediately gave, knowing that that was recurring VFib, they immediately got the drug in as quick as possible. We'd like to get it in within 10 minutes or less. Now, obviously, if you arrive late because you're the first or second response and you're down the way, you have to do it. You give it, they give the epinephrine, flush the tube, and then give the other drug. If VFib, VTAC returns, carry out the full ALPS protocol. Give the second set of drugs. Now, what?
Because we get stuck in Counts County.
Yeah.
And if we start the rock study, should we just transfer right to Southwest?
Oh, yeah.
Sorry.
Where else would you take them?
Well, St. John's.
Well,
But still.
actually, we have a kind of a deal with Matt McCoy. Anybody south of Kalama automatically comes here.
Can we even start the
No, no. If you're working as a Cowlitz medic at that point, I know, but I mean essentially you are. If you're working in Longview, you're working as and Longview is not rolled into that. They're not rolled into the study yet.
But what if we get them back, just take them right to Southwest?
Well, that would be that probably would be against Matt's orders, even though.
I don't know what his orders are.
Yeah. Well.
What are your orders?
Well, the thing is, you're not supposed to be working, when you're working in Longview, you're supposed to be working under his orders. You're supposed to be cross-certified or at least
We're
okayed.
supposed to take them to
Yeah.
John because generally the bird is there.
Yeah, and the nice thing is, if you get an
I walked in once and they had a cardiologist there and they
yeah,
treated
if you have an ROSC and you bring them into St. John, they will probably transfer them to us by helicopter anyway. Okay. All right. Looks like we're done.